and biochemical profile of metabolic syndrome in acute myocardial infarction. Sir, as we know, the metabolic syndrome is a constellation of metabolic abnormalities. It increases the risk of cardiovascular disease. Metabolic syndrome has 5 components: diabetes mellitus, central obesity, low HDLC, hypertriglyceridemia, and hypertension. This is an illustration of the metabolic syndrome and the 5 components of metabolic syndrome. Riemann was the pioneer of metabolic syndrome. He proposed the name Syndrome X in a lecture to the American Diabetic Association in 1988. He introduced the concept that the Syndrome X is a factor in the pathogenesis of hypertension, diabetes, and atherosclerotic coronary artery disease. These are the risk factors for CAD. Established risk factors like increased blood pressure, increased LDL, type 2 diabetes, and now we have the emerging risk factors like elevated triglycerides, abdominal adiposity, and low HDL. This is an overview of the pathophysiology of metabolic syndrome and aims and objectives of the study. Our aim was to study the prevalence of metabolic syndrome in patients with acute myocardial infarction admitted to our hospital and to assess and analyze the prevalence of individual components of the metabolic syndrome in acute MI patients admitted to our hospital. We have also assessed the 1-week in-hospital prognosis of acute MI patients admitted to our hospital. In the source of data, patients with acute myocardial infarction who have been admitted to our hospital during the period of 2012-2013 were considered for this study. Coming to inclusion criteria of our study, patients diagnosed with acute myocardial infarction based on WHO criteria, those more than 18 years of age, and those fulfilling 3 or more of the NCEP ATP3 criteria for metabolic syndrome were considered in our study. Coming to exclusion criteria, patients with non-cardiac chest pain and patients with chronic stable angina and unstable angina were excluded from our study. The NCP ATP3 criteria for metabolic syndrome, a patient has to fulfill 3 or more of the following 5 criteria, that is central obesity, triglycerides greater than 150 milligrams per deciliter, low HDL, increased blood pressure, and increased fasting plasma glucose. The WHO criteria for MI, it includes either rise and fall of cardiac markers, preferably troponin, plus at least one of the following 3, which includes symptoms of ischemia like chest pain, upper extremity, jaw or epigastric discomfort, ECG changes, that is new STT changes or new onset LBBV, development of pathological Q waves or imaging evidence of regional wall motion abnormality. These are pictures of acute myocardial infarction. We considered a total of 120 cases in our study. Of that, 51% of the cases were found to have metabolic syndrome. 48.4% of the cases were not found to have metabolic syndrome. Of these 120 cases, 88 cases were males and 32 cases were females. Mean age of the study group was 58 years. The youngest patient was 35 years old, the oldest patient was 81 years old, and maximum number of acute MI cases were in the age group of 51 to 65 years. That's 48% of the patients were in this age group. Coming to symptomatology, commonest presenting symptom was chest pain, followed by sweating, dyspnea, vomiting, palpitation, and syncope. Coming to metabolic syndrome patients, 74% of them had diabetes and 46% of them had hypertension. And of the metabolic syndrome cases, 63% of the cases were smokers and 10.5% of the cases had family history of coronary artery disease. Coming to the percentage of ST elevated myocardial infarction and non-ST elevated myocardial infarction, of the 120 patients, 76% of the patients had ST elevated myocardial infarction, of which 54% of cases were thrombolized. 34 patients received streptokinase and 16 patients received tenecteplase for thrombolysis. Coming to analysis of the individual components of the metabolic syndrome, diabetes mellitus was found to be the most prevalent component of metabolic syndrome in our study, around 74%, followed by high triglycerides 66%, low HDLC 62%, hypertension, and increased waist circumference. Coming to the comparison between patients with metabolic syndrome and patients without metabolic syndrome, The heart failure was found to be 38% in patients with metabolic syndrome and 15% in patients without metabolic syndrome. Similarly, VT or VF, re-MI and death were more in the patients with metabolic syndrome. Complications, development of complications like heart failure, VT or VF and death was found to be 3 times more in patients with metabolic syndrome than those without metabolic syndrome. So this is an illustration of the cardiovascular mortality associated with metabolic syndrome. As you can see, in metabolic syndrome in a study, the mortality rate was almost 6 times higher than in patients without metabolic syndrome. Coming to similar studies, in Karnataka, 2 studies were conducted, and we have the InterHeart study of 26,000 subjects, an international study on metabolic syndrome and myocardial infarction. In these studies, the prevalence of metabolic syndrome in MI was found to be 47%, 49%, but we have got it as 51%. In our hospital, the most prevalent component was diabetes mellitus, whereas in the studies done in Karnataka, low HDL was found to be the most prevalent component in metabolic syndrome. In comparison between other studies, even in the other studies, the percentage of complications were found to be higher in patients with metabolic syndrome than in those without metabolic syndrome. So conclusion is the prevalence of metabolic syndrome was high in acute myocardial patients and associated with worse in-hospital prognosis with development of complications including heart failure and case fatality. So an overview of the management of metabolic syndrome: lifestyle modification, weight reduction, diet intervention, lipid management, control of diabetes mellitus and control of hypertension are also important, along with physical activity. So the message from our study is diabetes and metabolic syndrome are driving the cardiovascular disease epidemic worldwide. Hence, early treatment of the components of metabolic syndrome like diabetes and hypertension can save precious human lives. I would like to offer my sincere thanks to all the staff of cardiology department, all the nursing staff, the staff of pathology department, and all senior doctors of SC Railway Central Hospital, and to my guide Dr. Bhanja, and to my co-guide our medical director Dr. Patnaik. Thank you.
In your study, you have shown that metabolic syndrome people, they have more complications.
Yes.
What is the time lag from the attack and start of therapy or presentation to the hospital? But that is the significant factor. Suppose a patient who got the attack and get admitted after 10 hours, and who is a patient who get attack and admitted within 1 hour. Actually, you start the treatment early and the complications, everything. So you have not shown, have you shown that thing? Any comparison? Because that time lag is the most important factor.
Yes, sir, definitely. If a patient with myocardial infarction presents early to the hospital, then a pharmacoinvasive strategy of thrombolysis was done, and definitely in early presentations, it has better prognosis.
You have not shown here in your study that you should have taken into account while you have present these cases, because that is most important outcome. Suppose
Yes.
percentage when you calculate, and the complications also, the death also, these things are, even if they are metabolic and not only you have shown a higher risk, but start the therapy and presentation to the hospital from the treatment to the start of the therapy, it is also equally important.
Yes, sir.
One more question is that incidence of STEMI seems to be very higher than NSTMI.
Yes.
But we expect that in metabolic syndrome patients are expected to have triple vessel disease. So how can you account for this disparity?
So it might be because ST elevated MI is more readily detected than non-ST elevated MI. So actually doctors also tend to detect ST elevated MI more, and non-ST elevated MI cases, they tend to be missed and even the mortality is higher. So that could account for the disparity.
And in your comparative study, I found that you have got less fatality than the other studies done
Yes.
elsewhere in India. Can you attribute this difference to use of tenecteplase at your center?
So definitely in our experience with tenecteplase, around 25 patients have been given, and there has been only one death. So tenecteplase has definitely a better effect than streptokinase.
So I think that should also be a take-home message for the audience, that in patients with metabolic syndrome, you should use a third generation fibrinolytic if possible.
Yes, sir. Yes.
Okay, thank you.
Thank you. Sir.